Inflammatory conditions of the jaws. Today's topic and today's discussion will refer towards the inflammatory process, inflammatory diseases that occurs most commonly in the jaw bones. Unlike the other bones in the skeleton, the jaws are unique in the sense that teeth create the direct pathway for pathogenic agents to reach and enter the bone tissue. Under normal conditions, as we know, bone metabolism is represented as balance between osteoblastic and bone production and the osteoclastic or bone resorption processes. Any type of injurious stimuli that alters the balance between cellular interdependent relationship with favor of either bone resorption or bone formation. Whether the source and origin of inflammation, direct from the infected pulp, as shown on this diagram, or from the fractured teeth, coronal part of the teeth, or indirect, the hematogenous spread from distant location, the onset of inflammation may be acute or chronic in progression and will be manifested by the four cardinal signs of inflammation. As we know, the four cardinal signs of inflammation that always follows the inflammation are as follows: redness, swelling, temperature, and pain. Some of these signs may be pronounced depending upon the phase of inflammation. For example, during the acute lesions tend to have a more rapid onset, causing pronounced pain, accompanied by fever and swelling and so forth. In contrast, the chronic ones are generally less severe, with more prolonged course, and pain is less intense. Whether acute or chronic, localized or generalized, dentists are responsible for determining the major radiologic features of inflammation and identifying the extent of the bone tissue involvement. Because periapical inflammatory processes provoke evident and unavoidable changes within the bone tissue that surrounds the affected tooth roots. So for the first step, we have to mention and discuss about the periapical inflammatory disease, periapical inflammation that surrounds the tooth roots. The term apical, in other words, its terms the apical periodontitis, is used to describe a disease process that involves the inflammation and destruction of apical periodontium of pulp origin, because the periodontal tissues and surrounding bony tissues are invaded from the infected pulp through the periapical canal during the periapical inflammation. The characteristic radiologic findings during periapical inflammatory disease depends upon the severity of infection and the host immune response towards the pathologic agents. So there are the two basic terms that are used for radiographic interpretation of the periapical inflammatory processes. The first is rarefying osteitis. Rarefying because of the resorption process occurred with radiolucencies, and osteitis because the inflammation of surrounding bony tissue. So rarefying osteitis is the radiologic term when referring to the inflammatory process in bone associated with bone destruction at the apex around the tooth roots. It's very finely shown on this diagram because of the beginning of the destruction of the surrounding bony tissue around these tubes. So it appears as the increased radiolucency, and is well depicted on these radiograms. Increased radiolucency. So these are the appearance of rarefying osteitis. In contrast, there are examples of, for example, there are examples of sclerosing osteitis. Sclerosing osteitis. This is used to refer the inflammatory process in bone with bone deposition around a tooth root. So sclerosing or hardening of bone radiologically appears as an increased radiolucency. Increased radiolucency, increased radioopacity of the bone. Or in other words, condensing osteitis is also used to better describe the latter condition appeared on the periapical imaging. The imaging features of periapical inflammatory disease may vary depending the stage of disease. Very early lesions, shown on this diagram, very early lesions may show very subtle changes, hardly identifiable changes. And sometimes the diagnosis may rely solely on the patient's clinical signs and symptoms during periapical inflammatory process. Clinically, these patients may complain towards the elongation of the root from the alveoli in reference to the other neighbor teeth that enables the patient to make the chewing motion on the affected site, and also the advanced or elevated tooth mobility is identifiable during clinical examination. So these are the very clinical changes that may indicate during clinical examinations towards the periapical inflammatory process in a given case. But more long-standing lesions may show evident radiolucent region at the root apex, shown on this diagram, with surrounding area of radioopacity, well depicted on this figure. Also, the increased radiolucent area that encircles the tooth apex, and also well corticated sclerosing bone formation and around these radiolucencies, also well identified on the lower molar teeth. Note that the periapical lesion develop within the apical portion of the periodontal ligament space, but less commonly and sometimes the lesions may arise from another region, and with which we will show it later, when the periapical inflammatory process will arise from another region, from another surface of the tooth root, for example, such from perforations of the root canal walls during endodontic treatment, or from additional non-adequately treated canals, or from root fracture sites. So we will show it later on our slides. The periapical bone tissue changes during periapical inflammatory disease varies from one that is narrow to that is broad, due to the chronicity of the process and the amount of peripheral sclerosis. This diagram shows the examples of bones rarefying and sclerosing osteitis affecting maxillary second premolar and the root of the mandibular first molar teeth. So we can identify the rarefying and also the sclerosing osteitis simultaneously on the same case, on the same apical part of the teeth. Note that the radiolucent region at the apex surrounded by the diffuse radioapical reaction of sclerosing bone occurs on these diagrams. But in some instances, as shown on this diagram, the tooth roots can undergo external resorption, but sometimes they may undergo the hypercementosis of the roots, and this is visualized as a bulbous-shaped roots. The external resorption or hypercementosis may be asymmetric and not uniform around the circumference of the roots. So this type of teeth possessing the bulbous-shaped roots is very hard to extract during surgical procedures because of hardening of the tooth roots and the changes of the apical part, enlargement of the apical part of the tooth roots during hypercementosis. Sometimes the periapical inflammatory process may involve the floor of the adjacent sinuses, as shown on these diagrams. So this is the maxillary sinus and its floor that is in close contact towards the inflamed upper second premolar teeth. And it shows the periostitis and sinus mucosal floor or mucositis of the sinus mucosal floor as a result of adjacent areas of rarefying osteitis due to the periapical inflammatory process of maxillary second premolars, as we have already mentioned above. Two types of lesions that most commonly must be differentiated from periapical inflammatory disease are the periapical cemento-osseous dysplasia, the first, and the second, dense bone bodies or dense bone islands located at the apices of the tooth roots. Both of them are shown on these given diagrams. The first depicts the periapical cemento-osseous dysplasia and at its early stage, and the dense bone islands that in most cases occurs on the posterior aspects of the jaw bones, especially near to the apices, near to the roots of the premolars and molar tooth. So let's have a little discussion about the periapical cemento-osseous dysplasia and its difference towards the periapical inflammatory process. In the early stage of radiolucent stage of periapical cemento-osseous dysplasia, the imaging characteristics cannot be used to readily be differentiated the lesion from periapical disease. In this case, the diagnosis may rely solely on the clinical examinations and by providing the pulp vitality testing. Because during the early stage or during the radiolucent stage of cemento-osseous dysplasia, as shown on this diagram, and this diagram also shows the radiolucent stage of early stage of the cemento-osseous dysplasia. During this phase, the vitality test conducted on the teeth in almost all cases are positive. So they show the vital pulp. In contrast to the periapical inflammatory disease that is almost always associated from the infectious spread from infected pulp. So in periapical inflammatory disease, the vitality test is negative and indicates towards the necrosis of the pulp. In contrast to the periapical cementous dysplasia that never shows the negative vitality test. But more major periapical cementodysplasia changes that is shown on this diagram focuses radio-opaque formations of immature bone inside the radiolucencies within the radiolucent area. So this very finding helps in the differentiate diagnosis and differential interpretations between cemento-osseous dysplasia and the inflammatory periapical disease, since the radioopacity seen in the periapical cementodysplasia occurs within the radiolucency in contrast to the periapical inflammatory disease, when the radioopacity is seen just at the periphery of the radiolucent from the radiolucent area, not inside or within the radiolucencies. So, in the major stages, those findings are crucial to make the differences based on the radiologic examination between cemento-osseous dysplasia and periapical inflammatory disease. The radiographic appearance of the dense bone islands, shown on this diagram, for example, may also mimic a focus of sclerosing osteitis. So, this is an example of the sclerosing osteitis with increased bone density, appeared as the huge radiopaque layer surrounding the enlarged periodontal ligament space, and this is the radiopaque area also located close to the root apexis, but without change in the width of the periodontal ligament space. So this is a significant and important differentiate sign between the occurrence of the dense bone islands that differs it from the sclerosing osteitis following the periapical inflammatory disease that inevitably shows the increased periodontal ligament space due to the inflammation spread from the pulpal tissue, the pulp chamber, to the periodontal tissues. So, also paying attention to transition that is narrow when we are dealing with dense bone islands. The transition to the normal bone structure is very narrow, but in case of sclerosing osteitis during periapical inflammatory disease, the transition is rather large between inflamed area and the normal trabecular formation structure of the jaw bones. So, sometimes also during the when we are identifying the when we are identifying the dense bone bodies, the apex of the roots may be somehow resorbed, but the resorption process is limited. Resorption process is limited and root apex may be blunted. However, retains a thin periodontal layer or ligament space can be visualized between the resorbed root apex and the dense bone islands. So now we have to discuss about another broad types very often and commonly encountered through the inflammatory processes that occurs in jaw bones, and these are the very profound changes of inflammatory in origin and in nature, and they are defined as osteomyelitis and periostitis. Both of them, periostitis and osteomyelitis, also represent the common inflammatory processes occurring in jaw bones and having relationship to untreated periapical inflammatory diseases progressed into more complicated stage with wide range of medullary and periosteal changes of bone tissue. Now let's define the periosteum, the connective tissue layer that encloses, and it's a very close contact to the all bone surfaces of the human body. It encloses the cortical layers of the jaw bones, and by the way, it encloses all the sinuses that are encountered throughout the head and neck skeleton of the individual's body. So, the periosteum and its characteristic histological structure reflects the specific cellular response to the inflammatory stimuli. The inflammatory stimuli is spread directly from the periapical areas or indirectly from the distant locations via the bloodstream. The periosteum, the periosteal connective tissue layer, consists of the two major layers. The inner layer, that is in close contact to the bone cortical surface, is represented with pluripotential cells with osteogenic activity. So the inner layer is of osteogenic in function, and the outer layer is the fibrous layer composed with the tough collagen collagen 1 type fibers. So the activation of osteogenic layer or the inner layer of the periosteum provides periosteal new bone formation. Periosteal new bone formation that is visualized, for example, in this case, is visualized with multiple radiopaque bone layer formations under the original bone, shown with a black arrow. This is the original cortical layer, cortical part of the bone marrow, its margin, and because of inflammation formed a new bone layer, several new bone layers that are associated towards the inflammatory process. So it appears as an onion skin and has an onion skin radiographic appearance that is very specific towards the osteomyelitis process. The osteomyelitis of the mandible with periosteal reaction located at the inferior cortex. This condition is referred to as the proliferative periostitis. Proliferative periostitis because of multiple new bone layer formation under an original bone. So, this kind of changes more often and in almost all cases commonly seen in children because of more loosely attached and higher osteogenic potential of the younger people's periosteum in contrast to adults. And clinically, this type of changes associated with the inflammatory bone tissue, inflammation of the bone tissue, bone marrow, and proliferative periostitis is manifested as unilateral jaw bone enlargement with subsequent exacerbations of inflammatory process. So, inadequate blood supply due to the inflammatory process exacerbation may lead to the hypoxia of the bone tissue sites, resulting in necrosis and formation, the dead bone particles within the inflammatory space, or in other words, gives rise to the sequestra, so-called sequestra. This diagram shows clearly identifiable radiopaque areas detached from the other parts of the bony tissue and embedded multiple increments inside the radiolucency surrounding these untreated and inflamed lower mandibular first molar. So we have mentioned the occurrence of sequestra or the dead bone particles. This is the hallmark feature of osteomyelitis that represents an important radiologic finding for bone marrow inflammatory process. So those diagrams show the mixed radiolucent and radiopaque pattern of apices of mandibular first molars. This diagram also shows the multiple areas of mandibular bone sequestration during the osteomyelitis, during the chronic course of osteomyelitis, in subsequent periosteal reaction and its onion skin-like appearance, and formation of the new bone layer below just the original layer of the bone. So this is a periosteal reaction and the sequestration. On this diagram, and also this diagram shows the radiolucent intermittent radiopaque areas during the osteomyelitis process of the lower jaw bones. So the images, these images, the axial and coronal views, computed tomography, reveal a large sequestration and periosteal reaction, by the way, of the inferior border of the mandible in osteomyelitis. Also, the multiple sequestrations within the body of the mandible and involving the condylar head of the jaw bones. So this diagram shows the involvement and the profound spread, more distant spread of the inflammatory process during osteomyelitis that may reach to the condylar process and also may reach the temporomandibular joint, causing the infectious disease of this part of the joint. So this diagram represents the panoramic and axial image of mandible involved with chronic osteomyelitis. Let's pay attention to the right segment of the mandible. The right mandible demonstrates the increased density and the increased size of bone tissue. The periosteal, this is the original layer, and subsequent new bone formation because the periosteal reaction during osteomyelitis. So the periosteal new bone formation and the original cortex layer are clearly evident on the axial imaging view. So, whilst presenting the specific radiologic features that is associated especially with the formation of sequestra, periosteal reaction, and formation of the new bone layer and its onion skin-like appearance, these are the major radiologic features that is characteristic towards the medullary inflammatory process of the inflammatory process of the jaw bones, or for the osteomyelitis. And whilst presenting the specific radiologic findings, besides all of these specific radiologic findings on the X-ray imagings, the clinical manifestation of osteomyelitis or acute or chronic course may resemble some other manifestations, some other diseases, including malignancies in adults. For example, acute osteomyelitis in children. Acute osteomyelitis in children has the unilateral appearance and is manifested as the unilateral swelling of the jaw bone. And this case requires an inflammatory lesion to be differentiated from a kind of non-inflammatory lesion, but also the lesion that appears unilaterally in almost all cases and also is manifested as expressed unilateral swelling. This is the fibrous dysplasia. The fibrous dysplasia, especially in adults and in children, and sometimes occurs in adults as an untreated type of fibrous dysplasia, is an uncommon bone disorder in which the scar-like fibrous tissue develops in the place of normal bone. So this irregular tissue makes the bone to appear larger, just in resemblance with the chronic osteomyelitis, but the enlargement of the bone is manufactured during fibrous dysplasia, is manufactured from within, and the cortex may be thin but does not change its location and does not show any sequestration or does not show any onion skin-like appearance. So those are the major radiology characteristic that differentiate the chronic osteomyelitis process, inflammatory process of the jaw bones, from the unilateral swelling, clinically appeared fibrous dysplasia that is non-inflammatory in origin. So another disease that also may clinically expressed as the swelling of the jaw bones is the Paget disease, but during the Paget disease we have to mention that the unilateral enlargement doesn't occur. The enlargement and the swelling of the jaw bones occurs bilaterally, so on the both sides, and the periosteal changings and new periosteal bone formation also does not exist during Paget disease. So the specific radiologic changes, we have to mention that sometimes are encountered in the patients undergoing radiation therapy after head and neck surgery of several types of neoplasms. In the alveolar process of the jaws, the most frequently occurring change is an irregular but uniform widening of periodontal ligament space around the teeth, as shown on these diagrams. So the first diagrams represent the previous X-rays of a patient prior to the radiotherapy, prior to the irradiation of a given anatomic site. And the second radiographs depicts the imagings after the irradiation therapy, and we can freely identify the disappearance of the lamina dura, for example on the second and the first premolar teeth. This tooth is almost extracted, and the widening of the periodontal ligament space. So these findings shows the examples of periodontal ligament space changes due to the radiotherapy prior and after the irradiation of the same patients. The images, we have to mention that the images were done after 6 weeks of receiving radiation. The combination of bone destruction and sclerosing with concomitant widening of periodontal ligament space is noticed after radiation. Osteonecrosis that sometimes occurs after radiation therapy, as these axial views shows the evident examples of the radionecrosis of the mandibular cortical areas with the mandibular buccal wall cortical layer sequestrations. So osteoradionecrosis may lead to the heavy sequestration of jaw bones, especially the mandible, because its vascularity specificities, losing the overlying mucosal coverings and exposing necrotic bone to the oral cavity. So on these diagrams, we can identify the sequestration of the cortical layer of the mandible after the radiotherapy of the same patient. So it, with its radiographic appearance, very resembles and mimics the radiographic appearance changes during the osteomyelitis process. So this diagram shows an example of radiation-induced osteonecrosis depicting extensive bone resorption and sequestrum. This diagram shows the image of patient with bone resorption, sequester formation, and bone resorption occurs secondary to radiation exposure, and the development of the fracture 3 months later at the affected site, unfortunately. The presence of osteoradionecrosis cannot always be diagnosed from diagnostic image, and often clinically obvious signs of exposed necrotic bone may not have the significant changes on panoramic image. So in this case, the computed tomography imaging is requested to identify the real changes that has taken place after osteoradionecrosis, after radiation therapy of the patients. So, radiation-induced widening of the periodontal ligament space, as occurs in this case, must be distinguished from the periapical inflammatory lesions of the teeth to avoid unnecessary endodontic treatment, or, in other words, tooth extractions, and in this case, the patient has lost his upper molar teeth. We see that it has already lost. In periapical inflammatory disease, we have to mention that the widest part of radiolucency, widest part of the periodontal ligament space appears at the apex of the tooth roots. In periodontal disease, the periodontal ligament widening appears in the gingival margin of the cervical part of the tooth root. But when we are dealing after post-radio therapy changes of the periodontal ligament space, the periodontal ligament space is widened, but it's uniformly widened throughout the whole surface of the tooth roots. And we also identify the loss of the lamina dura throughout the whole surface of the tooth roots and teeth presented to the irradiation therapy, exposed to the radiation. In some cases, the radiologic changes may demonstrate the similar appearances of medication-related osteonecrosis of jaw bones, and especially the chronic phase of osteomyelitis. So this diagram shows the example via the multi-detector computed tomography imaging. This shows the example of bisphosphonate-related osteonecrosis. So the bisphosphonate are the chemical drugs that are most commonly prescribed and used to treat severe types of osteoporosis and similar diseases, especially malignant in nature, which progresses with progressive demineralization of the bones with metastatic lesions, for example, to prevent loss of the bone density. So, the bisphosphonated related osteonecrosis has similarities with radiographic appearances towards the chronic phase of osteomyelitis. And this diagram shows the very clear example of a given case. So, we can identify the several sequestra in the anterior palate. So, it's very clearly noticeable on the maxilla, and also the single large sequestrum in the right posterior mandible, shown in the axial view and on the sagittal view on the computed tomography, on the multi-detector computed tomography imagings. Other reported findings also include the widening of the periodontal ligament space and thickening of the lamina dura. The patients that undergo subsequent intravenous drug administration during chemotherapy must remove the potential and real source of infection prior to chemotherapy procedure to avoid the complications related to medication-induced osteonecrosis of the jaw bones that sometimes may overlap with osteomyelitis. This diagram also shows the example of the prior and the post changes, mandibular bony tissue changes with sequestrations also appeared after the chemotherapy of the same patient. So, this shows the panoramic image. This is the panoramic image of the same patient taken after 1 year apart. We can identify development of the sclerosing bone and sequestration that is noticeable on the imaging following the bisphosphonate therapy. So, this diagram shows the bone exposed in the oral cavity due to the bisphosphonate therapy. This patient undergoes the bisphosphonate therapy and simultaneous corresponding extraction of the upper tooth root causes delayed healing of the lesion. In contrast, inability to heal the lesion because of the necrosis of underlying jawbone tends to expose the jawbone inside the external part of the oral cavity. So in this case, the lesion is secondarily infected, and the management for this condition is aimed at controlling the symptoms of pain and infection with antibiotic mouth rinses and systemic antibiotic therapy. So to avoid this type of complications with patients that undergo the chemotherapy, they must be prepared prior the beginning of the chemotherapy to avoid the profound complications due to the osteoradionecrosis and exposed bony, necrotic bony parts inside the oral cavity. So this lesion and this diagram represents the lesion of the uncured lesion of the fibrous dysplasia. This is the uncured type of fibrous dysplasia and shows the enlarged part changed with extrabeculation, enlargement from within the mandibular ramus and mandibular body, involving the coronoid process, also the condylar part of the mandible. So this is the appearance of the patient with the fibrous dysplasia, with this lesion, and it shows the well demarcated and well aesthetically seen enlargement of the lower jawbone. This is the radiogram also for the same patient with fibrous dysplasia, and that clearly depicts the enlargement and the generation, by the way, of the bony tissue of the mandible because of untreated fibrous dysplasia. This axial computed tomography view shows the axial view, also the enlarged mandibular part involved in fibrous dysplasia on the same patient, and increased radiolucent area that sometimes may resemble a cyst, but it's filled with fibrous tissue that is in almost all cases found in histopathological findings and smears of the fibrous dysplasia. The next diagram shows the hypercementosis or bulbous roots. During the hypercementosis, we can identify the thin layer of the periodontal ligament space. Also can identify the lamina dura, but increase the size of cemental layer of the tooth roots. So we have to mention that these types of roots are in some ways hard to extract during surgical procedures because of the thickening of the cemental wall inside the alveoli. So this patient or this woman visited the clinic because of compliance of the secondary enlargement of the lower jawbone due to the uncured fibrous dysplasia. This patient, you can identify the unilateral scar on the skin that indicates the previous opened type operation conducted on the lower jawbone due to the extraction of the excision of the excessive bony tissue because of the enlargement and of fibrous dysplasia origin. So this is the radiographic gross anatomic panoramic view of the enlargement site due to the fibrous dysplasia. And please pay attention that because besides the enlargement occurs unilateral sites, no sequestration and no new bone formation and onion skin-like appearance, just like during the osteomyelitis, chronic osteomyelitis process occurs when fibrous dysplasia. So this diagram shows the incorrect placement of the post during the tooth coronal part restoration, and perforation between the tooth roots of a given patient. So the rarefaction of the osseous tissue between the tooth roots indicates towards the periapical inflammatory process after failed restoration. This is another case of perforation of the wall of the root, because the incorrect also referred to the incorrect post placement already endodontically treated root. And also we can identify the evident rarefaction of the periapical bone, periodontal bone tissue changes. So this is an example of a patients with osteomyelitis with evident sequestrations, multiple sequestrations, and this is the solitary sequestra due to the osteomyelitis, inflammation of the jaw bones. So this is the appearance of hypercementosis, especially on the posterior roots, molars and premolar roots, and its clinical appearance is just as depicted on the upper diagram, but its radiographic appearance reveals its connection with hypercementosis. Sometimes these type of teeth are very hard to extract also, and the reason is very obvious. So this is another example of the failed treatment and the placement of the posture after endodontic treatment. You can identify the rarefaction due to the periapical inflammatory process and failed endodontical treatment, and also the rarefaction between the tooth roots of a given tooth, and also occurrence of the periapical inflammatory process. And this is an example of the same patient with the with the fibrous dysplasia that was almost already times before exposed to the opened type of operation, excision of the part of the enlarged mandibular body. So this is the operation with the intraoral approach for excision of the fibrous dysplasia, and please pay attention towards the gross anatomy structure appeared on the panoramic X-ray that shows the distant location, the very distant location of the lower third molar teeth, approximately near to the coronoid process. And after surgical procedure, the excessive layers of unused and fibrous dysplasia particles and excessive bones were extracted with the 8 molar teeth. So this example also shows the bulbous hypercementosis and degenerations of the apices of the tooth and rarefaction between the tooth because following the failed treatment, endodontic treatment of these second molar teeth. The extraction of the given teeth also is very hard because of the thickening of the periapical walls of a given teeth. So thank you for your attention.